So it's okay now.
Hold on. I'm putting on YouTube.
Okay. Take your time.
Yeah, it's fine. You have any videos?
No, it's just
Okay.
slides.
Okay.
I think I hope the hot seat taker, the four participants, I hope they are all at the time,
Okay.
so we can conduct the exam in a typical way. I think it will be interesting, you know, John, that asking a resident a lot of questions one after the other in the front at online setting. It will be a new thing to be seen.
Well, we'll see whatever you think works. You know, this will be a work in progress. We can experiment, etc.
Yes.
Because every week it's happening, right? So,
It will be each Friday, the first Friday of each month,
okay.
and I will readjust the timing because I put it 6 p.m. at KSA, and it should be 7 p.m. John, we will be 3 doing the exams.
Will I be free?
And me and Dr. Mati and Dr. Zahra.
Okay.
We are the examiner 3, and the hot seat taker, we will examine 4 residents.
Okay.
Okay. So all the questions should be targeted to all to only those residents.
Okay.
And
I will introduce you and you just run the show. That's essentially
yes.
it.
Yes.
Because I really don't know what you want, you know?
Yes, it's a new format.
Okay. Yeah, I'll let you run it. Let you run it.
Okay, thank you.
Whatever you need to do, just say, oh, I want to do this. I want to do that. You're in control.
Thank you. I think Dr. Zahra is joining us. She's one of the examiners.
Hi, Dr. Bennett, how are you?
Greetings.
Hi.
I'm Dr. Bennett.
Dr. House, how are you?
Hi, Zahra. Is everything okay?
Yes, thank you.
Hi. Good. I will stop this slide share.
Samer, did you talk to me?
Not yet.
Oh, okay. Oh,
I'm
it
ready.
must be an old message.
Yeah,
I just do some last minute promotion.
okay. I sent
Sometimes I don't pay attention to the screen. Like someone like Yuha had problems with the video or something. It stopped, but I didn't even see it. But someone else in the audience says, "Yo, Yuha, your video stopped." Because I was looking at other stuff.
Okay, I can understand that. Actually, I send you the PowerPoint slides just in case of connection problem. I put a copy in the messenger with you.
Okay. Check it. How's your group doing, Samer? You guys meet once a week or? Are you muted there, Samer? I can't hear you.
Actually, we are trying from time to time. It's not very convenient at the Corona time, you know.
Oh, right. Well, can you meet virtually? No, you don't want.
Not always possible because of different schedules. So
Right.
we prefer to do not a continuous series, more like interrupted activities, but it's always there.
Well, you'd be able to meet once a week here.
We are trying to do so. Actually, it's just time for doing final exams for medical students. And
The medical school is in session. They have classes.
Yes, they have final exams in their college. So
Okay.
I think after the mid of August, they will start giving presentation. They already prepared like 10 presentations about neurosurgery.
Uh-huh.
Just to start after the mid of August, I think.
Okay. Wow. So it's continuing. They're over here in Florida. They're going to start school in a week or two. It's going to be a big test to see what happens.
Yes, actually in Iraq, it's all virtual now, even the
It's
exam.
all virtual.
Yes.
Yeah, I was surprised they're even trying, but I don't think it's going to last long. I think that a couple of kids will get sick and all the parents will refuse, to send their kids.
Yes, yes.
Yeah, I think that's going to happen. Hello, Dr. Mati. You look familiar?
Hello. How are you, John? I hope you're doing well.
Yeah, how are you today?
I'm okay, thanks.
It's a nice poster in the background, brain surgery.
Yeah. It's the one from Operative, the complication
okay.
avoidance of a brain surgeries. Yes.
Oh, okay, very good. Okay. Isra Hashim is here. Awa Akram, how are you?
Hi, how are you?
How you know, I'm John Bennett. And you know,
Hi.
you know everyone else probably in the panel, except you
Yes.
don't know Big Daddy from Nigeria.
No, I don't know. Hi, everybody. I am Aufa Aksem, a resident neurosurgeon from a neurosurgical hospital in Baghdad, Iraq.
Well, okay, welcome. Welcome. Now, SAMER,
Yes.
yeah, I don't know what you want to do. If you want to introduce all the students, whatever you want to do, whatever.
Actually, I want to focus on, we are 3 examiners,
Okay,
me and Dr. Zahra and Dr. Mati, and we will introduce ourselves, and we have 3 or 4 hot seat taker. The
okay,
resident
tell me who they are, so I'll make them co-hosts. Who are the ones I should put as co-host? That'll put their screen at the top.
Dr. Zahra and Dr. Mati.
Hold on.
Zahra Fadl.
Oh yeah, there, I see her, okay. I'm gonna make a co-host, Zara. You probably get notifications, Zara. You're not accorded, you know, many privileges, but you're just put on top. You should be put on top. Who else, Samer?
Dr. Mati.
Oh yeah, okay. Okay.
And we need only the students that we will examine them to be not muted. All the other participants should be in mute form. Discussion with all the attendee will be at the end of exam.
Okay, I'll just let you run it, that's all.
Okay.
So are your students comfortable with the Zoom platform? You've used it quite a bit, right?
Yes, yes. Actually,
Really?
in all aspects, Zoom is now #1.
Yeah, well, it takes a while to get comfortable, I think, for a student to interact, and for neurosurgeons too.
Mm.
Once they get comfortable with it, they no problem interacting. But it's just getting to know it. It's decreasing the number of webcasts because I think people are kind of taking a breath after going like crazy for a while. Remember how crazy it was for a month, a couple months? Man, there were dozens every day, dozens. Now it's decreased. It's manageable now, and you can still see good ones every day.
I think the challenge is that the webinar came from different parts of the world, so at different timing.
Yeah.
Sometimes webinar at the morning, sometimes at night.
Well, you know, I find that it seems to be best late in the day for China. Like for UHAs, we have it at like 9 o'clock China time, but that turns out to be 6:30 in India, the afternoon in Europe, and the morning in America and Latin America. So that seems to cover most parts of the world.
Mm.
That is, if you really get people from China. Mustafa, well, this is not Mustafa from Wisconsin, I don't think. Got 7 minutes.
Okay.
How's Dr. Adi, the doctor, Iraqi doctor that wrote that paper on bullets from the sky? Dr. Kadi, is that his name? I haven't seen him for a while.
Yes.
Dr. Kadi, Oh, forget his name.
Hadi, Dr.
Like-
Hadi.
Right, right.
Ammar Hadi.
Right, but he's in Iraq, right?
And no, he's working in UK now. He moved
Oh,
to
he's in UK. Okay, because I haven't heard from him
He moved
in a
to
while.
UK maybe 2-3 years earlier.
Okay, now people are starting to come. Sometimes people wait till the last minute. Did any of the panelists get confused by the time? I don't think so. Because I checked it, I checked it. I thought GMT, I wonder what SAMER's main time is. I thought, well, probably GMT, that's his main. And you said 4 p.m. from the, you said 4 p.m. from the start.
Yes.
So I said, well, I'm going to stick with that 4 p.m. and work around that.
It's the mismatch will be only in the Arabic countries because we depend on KSA timing, which is Mecca time, and it should be 7, not 6. And I hope I shared the correction to
Okay.
an enough extent.
I'm just telling a panelist, yes, it will be available on YouTube on the Neurosurgery TV channel. I'm going to put the link to follow Neurosurgical TV, and then you get notices of all live conferences like this.
Yes.
You automatically get an email.
And do you know, John, I think that will be the first video available on YouTube showing an oral exam in neurosurgery.
Oh, really?
Yes, that will be the advantage of this video.
Well, this is going to be simulate a real life situation, a real.
Yes, yes.
Okay, you took the boards, obviously, right?
Sorry?
Yeah, you know what the boards are like, right? You took the boards.
Yes, yes. It's I took the regional board and for the FRCS UK exam, and there is multiple regional, local, and international exam. All are in a major extent a similar format, and that will be useful for all.
Oh, good. So you're going to simulate the real
Yes.
situation.
Yes, yes.
Oh, good. Because most people like myself don't know what a board exam is like. We hear stories,
Yes, yes, exactly.
but we don't really know what it's like.
Yes, exactly. John, it's not allowed to simulate a specific exam, okay, by all the examiner committee. But if you are doing such a simulation, a general simulation for oral exam, whatever the name, that will be acceptable, and that will be unique for these episodes.
Okay. Yeah, I mean, you can build an audience. I mean, it's not going to happen the first week. You just kind of keep building, stay consistent.
Yes.
Well, you did a long webinar before, 10 weeks, right? Before, so you know what it's like.
I think most of the residents are afraid of doing this exam in front of many audiences. But
it's tough, huh?
Yes, but I think after this episode, it will be clear that our target to simulate exam rather than to judge someone informations.
Okay, that's the starting point. Good, 3 minutes.
Okay.
For 30 people, that's good. Start. Yeah, we're getting a lot more interest from the Arab community, like in Egypt, a lot more interest. A lot of countries like Morocco, they're doing grand rounds now. It's great.
Yes.
I had a hard time getting Arabic speakers. Now I think it's easier.
I think with the time, they get more confidence and more trust of this type of presentations. I think initially they would say that what's the importance, but with the time it gets more clear, and I think with Corona it became more evident.
Yeah. Yeah, we had a really good one from Egypt. Five presenters. Yeah, it went well. We're doing another one, I think in a week or two. They wanted to do one right away, another one right away, which is great.
Okay, I will send a message for the all the participants
Okay.
asking if these names are there. So if anyone has his name on the message, please give us a talk. I want to know if they are there or not yet.
I am here.
Okay.
Okay, SAMER, you're almost ready?
Okay.
Okay, okay, let's start. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good afternoon, this is Dr. John Bennett broadcasting from Miami Beach, home of Neurosurgical TV. We are blessed with the presence of SAMER Hose, MD, a neurosurgeon from Iraq, also an educator that has a group of students that he's bringing along, students that are interested in neurosurgery. So I'm going to turn it over to SAMER. He's going to explain what he's going to do and run the show. Welcome, SAMER.
Welcome, John. Hi, everybody. We are here in the first episode of the VEIN competition. Its competition denotes a virtual exam in neurosurgery. The main target is to simulate oral exam or Viva examination. These examination, whether local, regional, or international exams. And we already have some actually courageous residents who registered themselves to take the first episode of the exam. And we will try to do the simulation. As an examiners, we are three. Me, Dr. Jose from Iraq, and Dr. Matti and Dr. Zahra. And for the resident who will take the hot seats, there should be Dr. Aufa and Dr. Osman. And I don't know if Dr. Mohammed or Dr. Ali are there. Please tell me before we start. So first of all, I will introduce the examiners, then the hot seat taker, and for all the other participants, I should ask them to put their question on paper or notes, and at the end of exam there will be an open discussion of whatever you want to ask. Okay, and now. Dr. Matti, can introduce yourself, please?
Hi. Hi, everybody. I'm Dr. Matti. I'm an Iraqi neurosurgeon practicing in neurosurgery in the Neuroscience Hospital in Baghdad, Iraq. I like neuroimaging. That will be part of my exam today in the VEIN competition.
Thank you, Dr. Matti. And now our brilliant Dr. Zahra.
Thank you, Dr. Hoz. My name is Dr. Zahra. I'm from Iraq. I'm interested in neurosurgery. Thank you.
Thank you. So for the hot seat taker, who's available? Dr. Osman. Hello.
Hi, how are you? My name is Osman Al-Amin. I'm a neurosurgery resident in Jordan, third year.
Okay. welcome. You should have a nerves of steel.
Yeah, already I'm nervous.
That's our target, and we will try to make a mask face during the whole test to put you in a more real situation. And Dr. Aufa, Dr. Aufa.
Hi, I am Alfa Aksem, final year resident neurosurgeon from Iraq.
Welcome to the test. And I don't know if Dr. Mohammed or Dr. Ali is there. Ali Malik and Mohammed El Haj. Okay, we want to be in time. That's the most important. I think we will start with both of you, Dr. Aufa and Dr. Osman. And if the other can join, we will continue the exam with them too. Okay, so for the general idea of the exam, I will start the slide share to describe how would be the flow of the examination. And please tell me if it's clear. Okay, so the vein competition, it's for the first time ever, I think, to do an online examination to simulate the real examination. We prepared this competition to be a simulation for any local exam, any regional exam, any international exam like the American exam or the FRCS European exam. All can be can benefit from this type of actually a trial, and it depends on hot seat. We cannot examine like many person at a time, but we will simulate the exam on a courageous hot seat taker, and it will be the first Friday of each month at 4 p.m. GMT, and sorry, it's 7 p.m. KSA. And we will provide, after the exam, we will provide the participant with certificate, and we will there will be award for the best performer in the exam. And this will be sent on email in a private. It's not to be shared publicly because the marks is not the target of our exam. And this is the first episode. The exam will compose of 3 stations, similar to the international exams. The first station will be non-operative, will be conducted by Dr. Zahra, and the second station will be about investigation, mainly neuroimaging, will be conducted by Dr. Matti, and the third station will be about operative and complication management, and will be conducted by me. So, starting with the station number 1, I will let Dr. Zahra lead the examination, and the hot seat taker, the ready hot seat taker now is both Dr. Osman and Dr. Aufa. So you can start, Dr. Zahra.
Thank you, Dr. Hoss, for the introduction. The first station, the Viva station, will consist of 3 questions for each hot seat taker. The first question will be of a neuroanatomy. Second is about physical examination findings that are pertinent to neurosurgery. And the third is about case dilemma, ethical case dilemma that's important to neurosurgery.
The sound is not clear.
Sorry, I'll say that again. So I'll be your examiner for Viva Station 1. This station, you'll get 3 questions per hot seat taker. The first one is a neuroanatomy question. Second, we'll ask you to identify physical examination findings that are pertinent to neurosurgery. And the third one is of an ethical case dilemma important to neurosurgical practice. Does that sound clear?
Yes, it's clear.
That's great. So whoever ready, Dr. Osman or Dr. Aufa, will start with whichever you prefer. So the next slide will, Dr. Osman, are you ready?
Dr. Osman.
I think he needs to unmute.
Yes. Dr. Osman, please unmute your computer.
Oh, okay. Okay. I think it was mute.
Okay. Okay. So this is the first question. I want you to name the structures labeled from 1 to 4, please.
Okay. This question for me?
Yes.
Okay. One, it's a cingulate gyrus. And 3, it's calcarine fissure. 4, it's calcarine gyrus. And 2, it's subcalcarine. Subcalcarine.
Okay. All right, thanks for trying. You'll see the answers on the next slide. Next slide, please. So as you correctly mentioned, 1 is the cingulate gyrus, 2 is the cuneus, 3 is the calcarine sulcus, as you mentioned, and 4 is the lingual gyrus, also named as the medial occipital temporal gyrus. Thank you. So the next slide is going to ask you to identify the examination finding. First, name the test for me and what's testing for.
Okay. Hold it.
Okay. You can see the answers on the next slide.
Yeah. Yes.
Okay. And that's the front-end sign for ulnar nerve palsy.
Yes.
And the third question is of an ethical case dilemma. This is Mr. X, a 65-year-old retired college professor who presents to the clinic with his 33-year-old daughter for a follow-up visit. You learned today that Mr. X MRI scan shows glioblastoma multiforme. Before entering the room, the daughter approaches you and asks you not to tell the father that the diagnosis was something serious in her words. The first question is, what would be your response to the daughter, A, and B, what ethical principles are involved in this case?
First of all, I will tell her. I understand your feeling, but this is the right of the patient. I should to tell him, and he should to know his situation.
Okay, and that's for A. What about B? What ethical principles are you following here?
The right of the patient to know his diagnosis, but of course it in the right way. I mean, bad break news.
That's a great answer. The answers are on the next slide.
Yeah.
So as you correctly answered, this is your duty of care to the patient for truth telling. You very correctly mentioned that you'll explore the daughter's concern, talk to her first, and this illustrating autonomy and beneficence. So we'll be moving on. Since there are only 2 hot seat takers, we will get 2 sets of questions for each of you, Dr. Osman and Dr. Alfa. So we'll be moving on to the next set with you again, Dr. Osman, if that's okay.
Sorry. Next slide.
We'll give you another set of questions. Again, neuroanatomy, examination findings, followed by an ethical case, and you'll be free from the station after that. Is that okay?
For me, okay. For me?
Yes.
Okay.
So the next slide is again a neuroanatomy question, and as we done before, I'd like you to name the structures labels from 1 to 4, please.
Don't you me who will answer or Dr. Osman?
It's up to you, but in general, the two of you will get 2 sets of questions.
Okay.
So you
Okay.
can take yours now, or yeah.
So I can continue, or?
Yes, if you can continue this one.
Okay. Number one, it's inferior sagittal sinus. Number two, I'm not sure, but it looks like the A2, anterior cerebral artery, A2. Number three, lamina terminalis. Number four, I think the stock, or yeah, I think the stock, the infundibulum.
So you got 3 of them correct, and the answers are on the next slide. Again, as you mentioned, it's the inferior sagittal sinus, the 2 segments of the anterior cerebral artery, the optic chiasm is 3, and 4 is the pituitary stalk, as you mentioned. Great. Next question is again asking you to identify this sign and to which syndrome does it belong.
Okay, this is called cafe au lait patches, and most likely associated with neurofibromatosis.
That's
Type 1
brilliant.
or type 2?
That's correct. Again, next slide will give you the answers as you mentioned. And the third is your last question, which is again an ethical case dilemma. This is a 55-year-old gentleman who was brought to the hospital after sustaining a fall. The CT scan shows an epidural hematoma requiring urgent surgical intervention. The GCS is sustained. You explain the need and the risks of the surgery, but the patient declined surgery. How would you proceed in this case, Dr. Osman?
Okay, and the patient, he came alone. Okay, he declined. So if I understand the question, he declined and refused the surgery?
Yes, the patient declines this urgent surgery.
Okay. I will explain to the patient exactly what the dangers of the situation, and may he will deteriorate more. And again, I will explain to him, if he refuse, then he should to sign refuse for the surgery. Otherwise, we cannot enforce him for surgery.
Okay, thank you for your answer. Your approach is definitely correct. And in the next slide, this is respecting patient wishes. And this touches on the principle of determining decision-making capacity for patients, which lies on 6 criteria. Once the patient fulfills the 6 of them, they are entitled to make treatment decisions on their own. Thank you, Dr. Osman. That's the end of the Viva Station 1 for you. You did a great job. Congratulations.
Okay.
Now moving on to Dr. Aufa Aksem. Dr. Aufa, whenever you're ready.
Okay.
So again, I want you to name the structures labeled 1 to 3, please.
Okay. Number 2, facial colliculus. Number 3 is lateral recess of the fourth ventricle. Number 1, opex.
Number 1 is what? Sorry, again?
Opex.
Okay. So thank you for trying. Most of your answers are correct, and the answers are on the slide. 1 is the area postrema, 2 is the facial colliculus, and 3 is the lateral recess of the fourth ventricle, as you mentioned correctly. The next slide is asking you to identify this sign, please.
This is sunset eye in pediatric age patient, mostly occur with congenital hydro.
That's brilliant. Thank you. Again, you correctly mentioned this is the sunsetting sign in hydrocephalus. And the next slide is again a clinical, an ethical case dilemma for you. This is a 12-year-old boy who presents with precocious puberty and headaches. Cranial imaging reveals a pineal region mass with hydrocephalus. an endoscopic third ventriculostomy is planned and discussed with the family, but the boy refuses to have the operation. He's aware that without surgery, death is likely. Question A is what's the next appropriate step in the management? And B, what are the elements of informed consent? Alpha.
I will follow what is the family want and do surgery since he's less than 18 years old for A. And element of informed consent, it will be for beneficial of the patient and do no harm.
Okay, thank you. And the answers again are on the next slide. So as you correctly mentioned, this is the issue for consent for minors. In this case, you only need the parental consent, but of course, you need a thorough discussion with the patients to explore their concerns. And the 4 elements of informed consent are, as you can see, information disclosure, competence, comprehension, and volunteerness. Next question is the other set for you, which again starts with neuroanatomy, asking you to label or identify the structures labeled from 1 to 4.
Number 1 is abducent. Number 2 is facial nerve. Number 3 is vagus. And number 4 is acranial nerve, vestibulocochlear.
That's brilliant. Absolutely correct, all of them. So the next slide again showing you the answers as you correctly mentioned, and moving on to the clinical examination. So can you name this test for me and tell me what's testing for?
This is test for median nerve, carpal tunnel syndrome. And the name is compression test.
That's brilliant. So again, the next slide is giving you the answers. This is the Durkin, or otherwise known as carpal compression test, and correctly testing for median nerve compression. And the last case for you is another ethical case dilemma, which is of a 45-year-old gentleman who's day 6 post-successful left MCA clipping. The patient's manager from work calls you requesting information about his healthcare status in order to determine his ability to return to work. So question A is, how would you respond if you were the neurosurgeon taking care of this patient? And B, which principles are applied here?
I will ask permission for A. I will ask permission of the patient himself about telling his manager the detail of his condition, and I will ask him to sign a written consent for that. A principle is applied here is like a trust between the doctor and patient, and not telling his condition, about his condition.
That's
before his
absolutely
agreement.
correct. That's brilliant. You're rocking it, Dr. Alpha. That's excellent. So exactly as you mentioned, then the next slide, you can see your answers. So you definitely need a written consent from the patient in this case, and this is addressing the issue of confidentiality. Thank you very much. That's the end of Viva Station 1. Thank you. And so I hope you found this station useful. The main goals of this station is to go back a little to the basics, to help you refresh your neuroanatomy knowledge, and to test your ability to answer case dilemmas under stress. And you did very, very well, both of you. Congratulations and thank you. I'll hand you on to Dr. Messi for Viva Station 2. Thank you.
Thank you very much, Dr. Zahra. It was so informative, the Viva Station 1 on the neuroanatomy and the neuroethics. Welcome to our hot seat takers. I will start with Dr. Usman. Are you there, Dr. Usman? How are you doing?
Yes, but I would like to tell you before I lost connection, there is some technical errors. Okay. I hope it will not happen now.
Okay, I have 8 cases. So we have 2 contestants now. So we have 4 cases for each one. Dr. Sam, can you start the neuroimaging by station 2? So now, this is the first case. A child male presented to the ER after sustaining a fall from height. Dr. Osman, can you interpret this imaging?
Okay, this is a brain CT scan, and showed and there is arachnoid cyst in the right side. The right temporal.
Right or left?
Sorry, there is arachnoid cyst in the left temporal area.
The left temporal. Can you more precise? What is in the temporal region?
Okay, I think there is. There is 3 types. I think 3 types of.
Yes. Before we classify them, can we say it is Sylvian arachnoid cyst? Is that right? It is a Sylvian arachnoid cyst?
Yeah, Sylvian.
Yes.
Yeah.
So is this arachnoid cyst, is it intraaxial or is it extraaxial? You know what we mean by intra and extraaxial?
Yeah.
So is it intra or extra?
It's extraaxial.
Yes, sure. Great. So do you know how the Hounsfield unit in this cyst?
Sorry.
Can you know the Hounsfield unit of this cyst content? You know the Hounsfield unit to measure the density?
It will be similar to the CSF.
Yes, which is? Can you give a numeric definition? Saying that the water is 0, so the CSF will be.
Forget the number exactly, but.
Okay, it is
I mean
5.
Hypo.
Yes, it is hypodense, so it is a +5. You can say from 0 to 10. That's okay. Yeah. Good. Can you classify these Sylvian arachnoid systems? Arachnoid cysts?
Yeah, it's classified to three types.
Right.
And
which type is this
small,
one?
This is type 1.
Yes,
This is
to which
type 2.
classification? No, it's type 1, as you say. According to what?
Okay.
Which classification?
According Glassry something.
Galassi.
Glassry.
Yes, the Galassi.
Yeah.
Great. So now, do you think this is related to the pathology of the fall, or it is an incidental finding in this brain CT scan?
Yeah, this is incidental finding with.
Yes, it's an incidental
CT scan.
Great. So now next slide, please. Next slide. This is the Galassi classification. Next slide, please, Dr. Samer.
And the answer is there.
Yes. Next slide, please.
Okay.
This is the Hounsfield unit. Okay. So next slide, we are in the same case. Now, this is the same patient. Now, his age is 16 years old. Presented 1 month after sustaining a head injury during a football match with disturbed level of consciousness. Can you interpret the imaging?
Yeah. Okay, this is the brain CT scan with left side subdural hematoma and extended to the it's in the left side
Any associated features in the CT scan?
Along all the bleeding extend to the cell, to the arachnoid cyst,
Yes.
to the temporal area, to the left temporal area.
Okay.
So the bleeding extend to the cell veins.
Any associated features? Any associated features?
Yes, there is midline shifting.
Okay, that's because
Midline.
of the disturbed level of consciousness. You are the neurosurgeon on call. What you are going to do as your line of management for this patient?
I will explain to the family situation of the patient, and he's the evacuation of the blood.
Okay, so you are going to evacuate by which type of surgery?
With craniotomy.
You perform craniotomy for chronic subdural hematomas? If I am the neurosurgeon on call, I would
either to be craniotomy or
bare hole, yes.
But for such patient, bare hole, for such patient, I don't think it's enough, because we would like to evacuate and explore the frontal area. I mean,
you
temporal
can do bare
area.
holes. In such situations, you are only doing the surgery for disturbed urohematoma. You are not treating the arachnoid cyst by itself. Okay, so find this. The next slide, the answers. Now you did well on the case one. Now case two. This is an adult woman with severe intermittent headaches. Can you interpret the imaging?
Okay. This is brain CT scan with hyper dense area in the third ventricle.
Yes, that's right. Great, go on.
Most likely this is a colloid cyst.
Great.
I mean, there is a lesion in the third ventricle.
Yes. What do you think is the content of this colloid cyst? Is it watery?
No. It's mixed most.
Actually, glue-like material. Okay.
Yes.
So the more hyperdense,
yes, glue-like
more glue.
material.
Okay. So you examined this patient and you found on the examination there is papilledema. What you are going to do? You decided to do surgery because of their papilledema. Okay. So which approach you are going to do for this patient?
Yeah, if there is papilledema. Okay, either to this patient doesn't have hydro. So I think transcallosal approach.
Yes, that's right. If she has hydro and the cyst is more hypodense.
Yes, at that in this situation, I think cortical easier.
You can do it by endoscopy. Okay.
Yeah.
Okay. So the answer is in the next slide.
Yeah, endoscopy one of the options.
Okay. Yeah. Okay. Now the case 3, again with you, Dr. Osman. So this is an adult man presented with disturbed level of consciousness. Can you identify these facial lesions?
Okay. This is it, I think this is the CPM or?
Yes, it is adenoma sebaceum.
CPM.
Can you adenoma sebaceum, right. Can you interpret the imaging?
Yeah. Yeah. Okay, this is the CT scan, brain CT scan, hyper dense area in the lateral ventricle, frontal horn.
Yes.
Also the, yeah.
You are doing great. So there is a cyst associated with it.
Yes.
So what do you think is the diagnosis?
Okay. I know it. This is tuberous sclerosis. This is tuberous sclerosis, but the brain lesion.
Yes. It's usually occurring in tuberous sclerosis associated with these facial lesions. The adenoma sebaceum is the SIGA, the subependymal giant cell astrocytoma. Okay, occurring in the lateral ventricle on the frontal horn. Okay. Next slide, showing the answers. Now, the last case for you, Dr. Osman, the fourth case. Can you unmute your microphone, Dr. Osman?
Okay.
So this is a 60-year-old.
Automatically.
Okay. So this is a 60-year-old woman presented with features of raised ITP. Can you interpret the imaging?
Okay. Okay. This is CT scan, brain CT scan with hypodense area in the left frontal area. Okay. It could be
contrast or non-contrast. Is this contrast or non-contrast, the brain CT scan?
Yeah, this is with IV contrast. Yeah, contrasted.
Contrast. So we have a left frontal cystic lesion. Does it enhance?
Yeah.
Does the wall enhance?
Yes. So
is there edema?
it's not enhancing.
You can see the medial. You can see the medial part of it is enhancing. Okay. There is edema.
Okay.
Okay. Can you formulate a differential diagnosis?
Oh, okay. It could be arachnoid cyst, but rather than arachnoid cyst.
Is this lesion intraaxial or extraaxial, Dr. Osman?
No. This is intraaxial.
Okay, so arachnoid cyst is extraaxial. We are not going to say it in the differential.
Yeah,
okay?
yeah. It's
okay.
It's not.
Okay.
Maybe any cystic lesion.
Like?
Dermoid cyst, but this is not the common site of.
Those two are extraaxial lesions too?
Far away, yeah.
Yes. Okay, that's great. You are third year and you did very well in the exam. Now I'm going with Dr. Alpha. because this is a tough question for you. Thank you so much, Dr. Osman. Hi, Dr. Ofa. I hope you are doing well.
Most welcome. Thank you for you.
Dr. Ofa, can you formulate a differential diagnosis for this case?
Yes, it is maybe abscess or glioblastoma multiforme. Also, I want to add something. In addition to that, large cystic with partially ring enhancement, there is a small multiple cystic lesion on the right side. It's very small area. I can see it when I enlarge the pictures.
No, we are going just with the left frontal. There is nothing else.
Okay.
So only these two?
Yeah, and
another thing, she is 60-year-old.
Metastasis could be.
Yeah, cystic metastasis. So next slide, Dr. Samer, please. These are the answers. Now, how you are going to differentiate between cystic metastasis, cystic glioma, and abscess? Do you want to request anything?
Yes, I will ask to study diffusion weighted images and MRS.
Okay. We are going with the diffusion weighted imaging. Next slide, please, Dr. Samer. Now, what is your opinion?
It is not restricted, so it is not go with abscess. It will go either metastasis or cystic glioma. So I will do.
Are cystic gliomas common in 60-year-old female?
No, it is uncommon.
So we are mainly going with cystic glioma, with cystic metastasis, right?
Right.
Right. That's the answer. This patient found to have a brave CA with metastasis to the brain. Great.
Okay.
Now, case number 5. This is a 32-year-old woman presents to the emergency department with head trauma. The patient is alert and oriented. You did examination. You found the cranial nerves are intact. There is no focal neurological deficit. Can you interpret the imaging?
Me or Dr. Osman?
No, you, Dr. Alfa.
Okay. This is
These are tough cases for Dr. Osman. Okay.
Okay. This is an axial non-contrast brain CT scan showing incidental finding, which is within the pinal region. It is peripheral. There is a cystic lesion with peripheral calcification. There is no sign of raised ICP nor midline shift. So mostly incidental finding.
Yes. What is the most common finding associated with pineal region tumors?
I will think of benign pineal cyst.
Yes, this is a simple pineal cyst. Okay. But usually you have to say if there is hydro or no hydrocephalus.
There is no hydro.
Okay. So what is your differential diagnosis apart from simple pineal cyst?
Could be pineoblastoma.
Pineoblastoma is more solid. You are going with a cystic lesion, which is?
Pineocytoma.
Pineocytoma, yes. What do you think? This is pineocytoma or a simple pineal cyst?
I don't hear you what you said, sir.
What?
I don't hear what you said. Sorry?
What do you think? What do you think this is? A simple pineal cyst or a pineocytoma, according to its size?
According to its size, it is a simple pineal cyst.
Yes, because it is usually less than 1 cm. 1 cm.
Yes.
Yeah. While pineocytomas usually up to 3 cm associated with hydrocephalus.
Hydro, yes.
Right?
Okay.
Next slide showing the answers, Dr. Samer. Okay. Now, case number 6. Okay. This is a 5-year-old boy presented with headache, nausea, and difficulty in walking. On neurological examination, we found papilledema and upgaze paralysis. Can you interpret the imaging?
Yes. First image is axial non-contrast brain CT scan showing pinal region lesion with heterogeneous in density. So there is central calcification and in the pinal region, and the other view with associated with hydro. The other is sagittal brain MRI showing pinal region tumor.
Which sequence? The MRI?
This is contrast.
Yes, contrast T1.
Yes.
Great. Showing what?
There is a heterogeneous enhancement of the tumor.
Oh, there is
the pinal.
not so heterogeneous. Okay.
Okay.
So what is your differential diagnosis for this 5-year-old boy?
According to his age, most common tumor in this area is germinoma or pineal parenchyma tumor.
Pineal germinoma or pineal, which is considered the penis. No, pineocytoma more in the adults.
Okay.
In the pediatric one, just like the penis, which is the pineoblastoma. Okay.
Okay. Okay.
Okay. Can it be associated with other tumors, the pineoblastoma in this age?
Germinoma can occur in cellular area also, so it will be synchronized germinoma.
Okay, that's for germinoma. What about the pineoblastoma? Can't occur with other tumors in this age, occurring in the orbit?
Okay. I don't remember.
The retinoblastoma with bilateral retinoblastoma?
Yes. It's trioblastoma,
okay.
Yes.
Yes.
Sorry.
Great. That's great. The next slide showing the answers, Dr. SAMER. Great. Now we have case number 7.
Okay.
Is Dr. Osman with us?
Yeah, yes.
This is a rather easy case, Dr. Osman. Can you interpret the imaging?
Okay. There is 2 imaging, A, brain CT scan, and axial view, and B, it's MRI brain T2.
T2, that's right. So what is your different? Yeah. What is the finding?
Okay, there is in the A, there is hypodense area.
Where?
In the CB, in the left CB angle.
Yes. Okay.
And in T2, it's
yes. In T2, it's hyperintense, right?
Yeah. So it goes with.
What is your differential diagnosis? Yes. Can you put a differential diagnosis?
Okay. Number 1, arachnoid cyst.
Yes. Number 2.
Epidermoid cyst.
Okay. So how you are going to differentiate between these 2?
I will go for diffuse. It will diffuse MRI.
Yes.
Diffusion. It will restrict.
Okay. Dr. SAMER, can you show us the answer? Wait, Dr. Osman. Dr. SAMER, can you show us the answers? Now the next slide, please.
Okay. Yeah.
So this is the diffusion weighted imaging. Can you interpret it?
Yeah. This it showed restriction. So this is epidermoid.
Yes. So this is an epidermoid. That's right. That's correct. Well done, Dr. Osman. Next slide, please, Dr. SAMER. So this is the final case, case number 8, and it is for Dr. Alpha.
Okay.
Next case, please, Dr. SAMER. So can you give us, Dr. Alpha, the diagnosis?
Without interpretation of the image?
Can you interpret the imaging?
Yeah. Yes, it is sagittal view of MRI T1 and STIR showing intradural extramedullary mass extend from lower border of C2 to C5, mostly lipoma.
Yes, that's right. Thank you, Dr. Ofa. Thank you, Dr. Osman. This is the
Thank you.
end of the Viva station number 2. I hope you enjoyed it.
Thank you for you.
Thank you so much. You did very well, both of you.
Enjoyed. Thank you.
Thank you, sir.
This is
Thank you very much.
the importance of the neuroimaging. You know that the neuroimaging is the basis for the diagnosis. You have so many incidental findings. You're going to tell your patient whether to worry about them. You do want to do surgeries or no surgeries. If you do want to do surgeries, the surgical trajectory will be dependent on this, as you will see with Dr. Samer Hoz and Viva Station 3. Thank you so much.
You're most welcome.
Thank you, Dr. Matti, for the nice station number 2, the investigation station. I think for us, while doing the international exams, this station is one of the most difficult, especially when you can add some electrolytes question or something like that with the detailed imaging, because in the exam, it's just like what you did, Dr. Matti. It's just one slide, and you should describe and amplify the case from that point. And our hot seat taker are doing well till now, and I'm happy they are still alive. So I think there is good news for you both that there is another participant will start with you now, so the cases will be divided. And now I will start with the Viva Station 3. It's about the operative neurosurgery, dealing with either approaches or complication, management of complication. And I think this is one of the most important parts to be assessed during the Viva exams. And I think that most of the fatal mistakes in the exam usually occur at this station, okay? When the patient should not be operated and you decide to operate, when the patient should be operated and you say, no, I will not operate. I think these are the fatal mistakes, and we should aware of that. And I will start. I don't know if Dr. Roshab is available. Dr. Roshab?
Yes, I'm available.
Okay. So I will start the operative station with Dr. Roshab, and then getting back to Dr. Osman and Dr. Aufa, so they can take some breathe. And Dr. Roshab, can you see the case number 1?
Yes.
So, according to this intraoperative image, what do you think, that we are on the right or left side, on the right ventricle or the left lateral ventricle? And why?
I'm not very sure with the image.
Okay, so it's an endoscopic view showing the foramen of Monro.
Mm-hmm.
And one of the important things while doing endoscopic approaches here is after entering, sorry, there is some noise.
I'm sorry.
There is a TV louder than me. So while using endoscopic approach, reaching foramen of the area of foramen of Monro, the surgeon should know that he's he or should confirm that he entering the right or left ventricle. And this will be the operative view. Can you identify any structure in the operative view?
That's the choroid plexus which we are seeing.
Yes, perfect. And there is vessels at 10 and 5 o'clock. What do you think these vessels are? Which one at 10 o'clock and which one at 5 o'clock?
I think the 10 o'clock vessel is the basilar vein, basilar artery, if I'm not wrong.
Okay. And the 5 o'clock vessel?
I'm not sure.
Okay. And the message here is that for all the procedure, while preparing for your exam, for all the procedure, you should know the principles. Okay. If you know the principle of all the neurological procedures, just the main principles, this will guarantee you to pass the exam. That's the idea. It's better than mastering many projects and many approaches and leaving others. Okay, that's the main message for all. I can go to the next question. If you know it, Dr. Robash, do you know the blood supply of this choroid that you already identified?
The anterior choroidal artery.
For this segment specifically? Okay.
No, I think.
Dr. Alpha and Dr. Osman, can you provide any help?
Yes.
Yeah, Dr. Osman, yours.
Yes, Dr. Alpha, yes, you are my senior. Go.
No, you can answer it. Answer it, and after you, I will reply.
Go on, Dr. Osman.
Okay. So this is endoscopic view of the lateral ventricle, and this is foramen of Monro, and we identify the site of foramen of Monro. We should to follow the choroid plexus. So when it's right, left.
Choroid plexus.
And
what?
Then foramen of Monro at the choroid plexus, yeah, venous angle, yeah. So this is the thalamus striate with septal vein.
That's nice. Where is the thalamus striate and where is the septal vein? Which one at 10 o'clock and which one at 5?
Okay, 10 o'clock, this is the septal vein, and thalamus striate 9.
Okay, so back to the question, you can decide it's right or left lateral ventricle from the relation of choroid plexus to what?
Choroid plexus to the septal vein, to the foramen of Monro.
Another option? Actually, it's to the thalamus striate vein. And the typical answer will be it's the relation of the thalamus striate vein to the choroid plexus. If the thalamus striate vein to the right of choroid plexus, as in this case, so we are in the right ventricle. If the thalamus striate to the left of choroid plexus, so we are in the left lateral ventricle. And what about blood supply, Dr. Osman? Any idea?
Of the choroid plexus?
Yeah, yes, at this segment.
From I think from posterior cerebral artery.
Sorry,
it's the choroid artery from it's one of the branches.
Okay.
Cerebral artery.
You will find in the answer. Indication.
One of the arteries, choroidal artery from the posterior cerebral artery.
Okay, I get you. And what's the main indication to use this approach?
Okay, when we are going to do endoscopic third ventriculostomy, ATV.
Another indication, yes, that's right. Another indication.
If there is tumor in the third ventricle also.
Perfect.
Any lesion of the third ventricle.
That's perfect. The blood supply here mainly comes from the medial posterior choroidal artery. That's the main supply. Anterior choroidal artery may give supply to the choroidal plexus up to the foramen of Monro, but to a lesser extent. And even the lateral posterior choroidal may have a few contribution, but the choroidal plexus around the foramen of Monro, the main supply is the medial posterior choroidal artery. Main indication, as you said, third ventricular mass and ETV. Back to Dr. Robash. Are you alive?
Yeah.
Okay. So this 70 years old male has a history of transcranial surgery before 10 years and now presented with this MRI. What's your idea about the possible approach in general?
I feel, I feel there can be two approaches to this. The first approach can be the transnasal or the transphenoidal approach, for which the sellar mass can be excised and then go transcranially through the right sylvian fissure to excise the suprasellar mass.
So you are advising to use a combined approach for this lesion?
Yes, sir.
Which one?
Or
first?
we can go, or we can say for a single approach, we can go transcranially through the sylvian fissure and for the excision of the mass.
Okay, so let's put it more clear that what's the indication of a transcranial surgery in this patient? If you want to do a transcranial, what's the feature that indicates a transcranial surgery obtained from imaging?
The involvement of the ICA by the tumor, if I'm not wrong, because the images are not.
Another point.
Another point would be
because involvement of the carotid artery usually occur with the pituitary tumors and can be managed on both approaches. My question is indirect question about what are the contraindication of transphenoidal surgery. As you know that pituitary up to 90-95% should be done through transphenoidal surgery, but there is certain contraindication as shown in this case that may render the transphenoidal approach contraindicated or relatively contraindicated. Okay, any idea, Dr. Osman?
Excuse me, I lost the connection.
Okay, any idea, Dr. Aufa?
Yes, first of all, the patient is already operated by transcranial surgery, so I will do the same. I will open the same flap. It also there is a large suprasellar part of the tumor extend into a frontal cranial fossa, and I want a CT scan to determine if there is a calcification part or not. In addition, it is already encased both carotid according to the size and according to the coronal section.
Okay, I have happy news for all of you at this station that you failed. Actually, this should be straightforward. That lateral extension or frontal extension of pituitary tumor, major lateral extension or major frontal extension is the contraindication for transsphenoidal surgery. Okay, it should be clear like this to be a perfect answer in the exam. And again, for the same case, I'm continuing with Dr. Robash also. This is the post-operative CT scan, and 2 months after the surgery, the patient came to you, the same patient came to you with left side weakness and within the last 2 days, acute deterioration of the power of the left side within the last 2 days. So what do you think about the possible causes here? Is the question clear? Dr. Robash?
No.
Do you hear me, Dr. Robash? Okay, Dr. Osman, are you there?
Yes, but I didn't understand the question.
Based on this post-operative CT scan, the patient is doing well. Patient is doing well, and with this post-operative CT scan showing resection of the major part of the mass with no complication. 2 months after the surgery, the same patient presented with acute deterioration, left side weakness of a grade 2, power within the last 2 days. What do you think as possible causes when you receive this patient? Is this something related to the surgery or not?
It could be, but there is a range of differential in such cases. So maybe unlikely to related to the surgery after 2 months, but still it could be.
So, and the top of your differential will be what?
Maybe any hemorrhagic event or recurrence.
Okay. Recurrence, hemorrhage at the site of surgery, another option, another possibility. Yeah. Is there a possibility of stroke, infection, abscess?
Yeah. Yes. All of
Okay.
Yeah.
So the patient did an MRI, and that. Can you describe it now?
Okay. This MRI with this
if you compare it with the CT scan just beside it, there is a new finding.
Yeah. Yes.
Okay, which is
this goes with edema.
Would you pass this answer to Dr. Alpha?
Yeah, better.
It's like doing just please next. Okay, because it's a rare case, but I want to test your logic, your neurosurgical logic. What would you think that neurosurgical logic will appear clearly while dealing with rare cases? That's the idea. It's not about ask that you should know this rare complication or rare finding. It's not about this. It's about how would you think in such situation. Okay. So Dr. Alpha, do you have an idea about this?
When
Any
I see this,
possibility?
when I see this axial MRI view, I will first of thing come in my mind is abscess.
Okay.
But
So
I
we also
I will-
think that it's abscess.
I will ask
Uh,
for Dewey, but for Dewey.
Okay. Actually, we did this CT scan. Dewey is not available there. And what do you think based on CT scan?
This is air.
Okay. So would the air cause midline shift?
Only
Why?
in one case. If it is large enough, as in tension hemocephalus.
Okay. So this is the progress in the exam should be, as you said, that abscess is the most common differential in this situation. And this CT scan showed that it's air-filled cavity and causing the midline shift. Sometimes abscess with air-producing organism can cause a few aerosol within the cavity, but not such a cavity filled with aerosol. And if you find the source, so it's actually it's a rare case of tension pneumocephalus, one of the complications. Okay, so I don't know if Dr. Robash is there. Okay, let's try to check him. I want just to know if he's alive or not. It's not about the exam. And Dr. Osman, yes, can you try
Yes,
for this? Dr. Robash, are you there?
Yes, I'm there.
Okay. So, do you have an idea what's this intraoperative image? I think you are lucky with the with the intraoperative images.
Somehow I feel it's a picture showing trigeminal neuralgia and ICA abutting the trigeminal nerve.
Perfect. So it's intraoperative view of microvascular decompression or during microvascular decompression of trigeminal neuralgia. This is perfect. I think the instant shape of this nerve, this size nerve, should be seen in two locations only, either in the optic or in the trigeminal. This size nerve. That should be.
I agree.
Yes. So, Dr. Robash, any idea about the side? It's not a main question. It's just a side question.
I think it's the left-sided.
Why?
The ICA is running over the trigeminal nerve from the left.
Perfect, but it's not ICA. It's the superior cerebellar artery, which is the common. Yes, which is the common culprit here, superior cerebellar. And if the loop comes from above, as in this case, so it's more in the direction. So if you open a case of microvascular decompression, like for trigeminal neuralgia, and you don't find a compressing vessel, what do you think? What to do?
We'll be checking with an intra-op neuromonitoring if there is an problem with the if there's an a conduction abnormality with the trigeminal nerve.
Let's say it appears to be the conduction was normal, but still the patient has trigeminal neuralgia that indicate the surgery. Intraoperatively, you usually found a compressing vessel, whether artery, which is commonly, or vein rarely, but sometimes there is no compressing vessel, neither artery nor vein. If you don't find a compressing vessel on the nerve, what?
I'm not sure for the answer.
Dr. Osman.
I will try to do dissection and make the nerve free, putting Teflon between, even if there is no compressing, I will do dissection to make the nerve free and arteries free. I mean, I will dissect the membranes around the
Okay.
trigeminal nerve.
Nice idea.
Also, maybe I can.
Another.
Also, I heard, or I heard some surgeon they can suture the tentorium or something like this, or they make more space. The general idea.
Okay. It's a common exam question, although the answer is not quite easy. And to know the right from the left, it's the right side because the supracerebellar comes from above. The common culprit vessel for each trigeminal neuralgia, facial spasm, and glossopharyngeal neuralgia should be ready in your mind. And if you find no compression, even at no venous compression, you can do a rhizotomy, either squeeze the nerve. Sometimes surgeon can do bipolar, and rarely to transect part of the nerve because this may cause anesthesia dolorosa. So the perfect answer is to squeeze the nerve with arterial forceps if you didn't find any compression. Moving to the next case. Dr. Robash, are you there?
Yeah, yes.
Okay. I know that you are not ready for the exam and you join at the last minute, but
Yes.
I appreciate that. And actually, I want to make all of us get benefit from this discussion. So
Thank
again, welcome. And I told you that because I want to increase the stress level because the next question will be more difficult. What do you find in this CT scan?
There's SAH in the Sylvian fissure, the interhemispheric fissures, and the basilar cisterns.
SAH, subarachnoid hemorrhage. So we did CT angiography for this patient, and we found this. What do you see in this imaging?
So there are multiple aneurysm. One is in the ACOM, and the second is in the M1 segment. I think, yeah.
Perfect.
M1 segment of MCA and the left side.
ACOM and left MCA. So the next question, which is a usual exam question, what will you do if you have multiple aneurysm, subarachnoid hemorrhage? Which one is the bleed? Which one is the source of bleeding? How do you know?
Because the patient is having such a dense SAH, I would like to see the GCS and the WFNS grade initially, and subsequently decide. According to the CT which has been shown to me, I think it seems to be a left MCA bleed because of the thick collection of blood within the interhemispheric as well as the Sylvian fissure and the basilar cisterns.
Okay, that's I'm asking specifically on the steps in mind while dealing with multiple aneurysm to find which one is the source of bleeding. It's not specifically about this case. So if you have such a case, and what you should bear in mind, you said that from the subarachnoid hemorrhage in the CT, I can have a clue about which one is the source, isn't it?
Yes, yes.
Is there another steps that can be helpful to have a clue about the source of bleeding?
Depending on the WFNS grade or the history of the sense.
WFNS
weakness if any, if the patient is having.
Another point. Dr. Osman, you can answer if you have a point in mind also.
Unfortunately, the internet connection with me very bad, so I lost a lot of things. The last thing I heard from Dr. Rabish when he commented about the ACOM and MCA, aneurysm, multiple aneurysm. This is the last thing.
Okay. I can guarantee nothing, you will miss nothing because all are recorded and will be available on YouTube. Just to save time, I will move to Dr. Aufa with the same question. What do you think in case of multiple?
In case of
Yes.
multiple aneurysm, to determine which one is ruptured, I will look for radiological sign, and then I will look clinically. In radiology, I will search for the area of maximum thickness of subarachnoid hemorrhage, or if there is an ICS. And I will look for Murphy teeth, a daughter cyst, a daughter aneurysm, and I will look if there is in CT angio, I will look if there is a vasospasm. And clinically, I will look at a site of weakness in case of MCA. I will search for cervical palsy in case of PCOM aneurysm, and behavioral changes or disturbed level of consciousness.
Okay, I cannot judge the clinical signs to localize which aneurysm is the source of bleeding, but this is clearly shown a stepwise fashion in the Greenberg handbook that you should first search of the epicenter of blood on CT, as Dr. Robash and you just said. Another point is to search the focal vasospasm, also irregularity in the shape aneurysm like daughter cyst or Murphy teeth, and if all are the same for both aneurysm, we should suspect that the largest aneurysm is the rupture one. And if another clue, if all the 4 factors are equal, try to consider ACOM. Actually, in this case, the ACOM was the rupture one. Okay, because it's the most common to rupture and the most common in general. I think I will start this with Dr. Osman.
Yeah.
This station is not about the imaging, it's about the surgical approaches. So this is a cavernoma. Can you identify the specific location of this lesion?
Okay.
Can you describe the location of this cavernoma?
Okay. This is cavernoma in the left hemisphere of the cerebellum.
Okay. Only cerebellum?
No.
Only hemisphere?
Yeah, in the left side, attaching the breast.
Yes. The attachment between cerebellar hemisphere and the brainstem is the middle cerebellar peduncle.
Yeah.
So this is mainly a middle cerebellar peduncle cavernoma. And the main question for you is that what are the possible approaches here?
Okay. I think this. I think transvermian difficult for this lesion. I'm not sure. Or retrosigmoid. I'm not sure.
I'd like to each possible approach with the pros and cons.
Okay.
What are the possible approaches first? The advantages and disadvantages of each.
For me, the question difficult, and number 2, again, really, I have a bad connection. So this is make me. Hello, I lost everything now, even the. Hello.
Osman, everybody lost it for a while until it come again.
Okay, thank you. Okay. So this is
So,
this
Dr.
is-
Osman, you
yes.
are lucky enough you stopped the slides.
Yeah.
So, yes, and I want to make it more speedy, please. What's the approaches in mind?
For me, okay. I said retrosigmoid and transvermian.
Okay.
Yeah.
Dr. Alpha. Dr. Alpha, another
okay.
possible approach.
The transfer, I will start by retrosigmoid approach, transcortical, to reach this cavernoma and to be away from the DVA, which is located medially to it. The other approach, which is mentioned by Dr. Osman, midline suboccipital craniectomy transvermian, but the DVA will be just in front of me in the surgical field, and it will be difficult maybe to remove it without difficult to remove it while he's in the middle of the field. Another one is far lateral approach, but I will not use it.
No.
I will prefer retrosigmoid approach. Transcortical.
What do you mean by retrosigmoid? Retrosigmoid means using the subarachnoid space in front of the cerebellum to get access to the CPA. So, is this approach is the easiest one, and why?
It is easier. It will be. It is easiest to because there will be less cortical damage.
From where will be your entry point?
Lateral. Transcortical. It will be. It will be
Lateral what?
transcortical. Transcortical.
Which part of the cortex, of the cerebellar cortex? Because Dr. Robash, do you have another idea? You can add something, or I proceed with the answers?
So you can proceed with answers.
Okay. And actually, this lesion can be attacked from 3 different angles, either using the retrosigmoid approach through subarachnoid space, and the entry point will be the middle cerebellar peduncle external surface. And the other approach, which is described by Dr. Spitzler, is the midline transvermian transformed ventricular approach to reach the medial side of the lesion. And a third suggested approach is transcortical transcerebellar through the mid part of hemisphere to reach the lesion from the posterior end. So the approach is either to reach the medial end of the lesion or the lateral end of the lesion or the posterior end. All are possible here, and all carry its limitations. I just want to listen about your judgment about the pros and cons. It's not about deciding the perfect one. Actually, Dr. Aufa said about this vessel just medial to the lesion. That's very important here to decide. And usually the cavernoma associated with the vessel. Dr. Osman, do you know this category of vessels? What's the name for these vessels? Just run close to the cavernoma.
I forget it.
Okay, so this is the same case. You can find this large vessel looks like basilar artery, but it's behind the brainstem, not in front of the brainstem. And this is called the DVA, developmental venous anomaly.
Okay.
Okay, that's commonly associated with cavernoma and should be preserved because it's in normal anatomy. So, actually, for this case, we decided transcortical transcerebellar, and it's evacuated. Anyone familiar with this approach? Because it's difficult, I will put it as open question.
I see.
Yeah, I know it.
Yeah, okay. Dr. Osman, what's the name of procedure?
I saw it in the Kaizen lecture.
Okay, what's the name of procedure?
This is internal carotid endarterectomy.
Perfect. It's right or left side?
Okay.
No,
I
but
don't know, but
serious.
you know, I don't know, but maybe this is right. Maybe right.
Why?
I saw this is the external carotid and this is the internal. And
To the left side, to the left side is the common carotid. To the right side, both the internal and external. And what do you think? Do you see the pointer? My pointer?
Yeah, I saw. Yes.
This is a branch. So what do you think this vessel is?
Okay, this is if this is a branch. This is the external carotid, and this is the superior thyroid artery.
Perfect. And so this is the left side. And my question here is the common question for this approach. It will be of 3 parts. The first part, what's the indication?
Okay. The indication of this, it's the block of the artery, the internal artery, atherosclerosis.
Okay. Any specific degree of stenosis?
More than 90%.
More than 60% or cases having symptomatology.
Yes. Yeah. Do you know which trial describe the effectiveness of this approach? Any idea about the trial?
There are multiple trials. The most important trial was the CREST trial, carotid revascularization and endarterectomy trial.
Okay, another trial compare its effectiveness with the stenting.
The SPACE trial?
The NASCIT trial.
The NASCIT trial was the medical management with the endarterectomy, if I'm not wrong.
With the endarterectomy.
Yes.
Actually, it's still evident that the surgery is comparable to the stenting. And yes. My next question is about what's the order of putting clips at the beginning of surgery? The arterial clip, there is a specific order?
It's Osman, the internal
the order. Oh, okay, Dr. Robash, I'm with you.
It's the internal carotid followed by common carotid, and the external carotid.
Perfect. And the order of removal of these clips?
It's the reversal. It's the external carotid, the common carotid, and the internal carotid.
Okay. Can you tell me why to remove the external carotid clip first?
It's basically so that while opening of the common carotid, the thrombi or the turbulent flow which is created is initially flushed in the external carotid and not goes into the internal carotid, causing stroke.
Yes, that's perfect. We should open the external carotid first for any debris to go through it and not causing stroke. Then the common carotid to flush the area, and the final part to open the internal carotid artery clip. So, Dr. Robash, you look familiar with this approach. I will continue with you. What do you think this yellow arrow describe? I think Dr. Osman already described it.
It's a superior thyroid artery from the external carotid.
Yes, and the green one?
Just a moment. This is the facial artery? Superior maxillary artery.
No, it's not artery actually. Try to think of other options.
Vagus nerve.
Vagus nerve. Vagus runs horizontally. This structure runs horizontally over the vessels.
Actually, I have 2 or 3 things in my mind right now.
Yes, Pour them out.
It can be an ansa cervicalis or
Is it
or it can be a muscle sternohyoid. I'm sorry, it's a horizontal belly of digastric. I'm sorry. It's a digastric muscle.
Okay. Actually, this is a nerve crossing the upper part.
Nerve?
No. Glossopharyngeal nerve do not cross the vessel in this fashion. This is the hypoglossal nerve. It's the only nerve.
Ansa cervicalis? Is it the ansa cervicalis?
No, hypoglossal, yeah.
Ansa cervicalis is a small branch arising from this hypoglossal that runs anterior to the carotid sheath. We already opened the carotid sheath. The idea is that there is a nerve runs horizontally in the upper part of the field, and usually this is the upper limit of the field, which is the hypoglossal nerve. Okay?
Yeah.
Now, who is the hot seat taker will want to take this question?
Me.
Okay, Dr. Osman.
Okay, number one, this is the optic chiasm, and we are, this is
wrong, and?
Wrong, okay, so it's the optic tract.
No.
Really?
Number two.
Okay, number two, I will say this is the anterior cerebral artery.
Number three.
Okay. Number three. I'm not sure. It's artery, isn't it?
Yes.
Okay. This is the. I'm not sure.
4, 5.
4. Okay, for the is it? I think this is the olfactory, or
5.
the rectus gyrus. For rectus gyrus.
Perfect.
Okay.
Which rectus gyrus, right or left?
Inferior frontal gyrus. This is the right side.
The approach is right terional approach, but number 4 is the left gyrus rectus, not the right. It's from the other side.
Okay.
Number 5 or 6, any idea?
Okay, number 6. This is the before 6, the internal carotid artery. So this is the it's anterior choroidal artery or posterior communicating artery. It's anterior choroidal artery.
Why?
Because it's the branch before communicating. So either to be one of either to be anterior choroidal artery or maybe.
Any idea about 5?
Okay, 5. Of course, I know it, and I saw it before, but
Dr. Rovash, can you provide any help?
Is it the pituitary?
Just close. Yes, it's the pituitary stalk, the only longitudinal striation that can be seen in the opticocarotid space. So this is the pituitary stalk, definitely pituitary stalk. Okay. Any idea about number 1 and 2, Dr. Robash?
Number 2 is recurrent artery of Hubner, if I'm not wrong.
Perfect. It's not the anterior cerebral, it's a branch arising from anterior cerebral and the cross back. So it's the recurrent artery of Hubner. Number 1. If we want to choose the chiasm, so we put the pointer just in front, but at this location, we are asking about what?
I think it's lamina terminalis.
Perfect. And the number 3?
Number 3 would be the ICA of the MCA of the opposite side.
Yes. Between the optics, you can find the ICA of opposite side, and number 3 is the MCA of opposite side, of left side. That's good. And moving to the final case, and you said number 6, correct, Dr. Osman? It's anterior choroidal. Why it's anterior choroidal? Because the direction is posterior superior, while the posterior communicating will be more posterior, will be directed toward the temporal, while the posterior communicating will be directed to the brainstem. And in most of the terminal approach, you can see the anterior choroidal before the PCOM. That's one of the important points. And Dr. Robash, are you there?
Yes, yes, yes.
So this is the last case for the operative. What do you think about the mechanism of injury, the specific mechanism of injury in this patient? An adult patient, history of trauma.
A gunshot injury?
Gunshot?
Or
which type of gunshot injury?
Which type? I'm not sure about the type of the gunshot injury, but I can see multiple pellets inside. So,
where is the pellets?
on the left side cerebral hemisphere, the hyperintensities, which we can see.
Where? Sorry?
On the left cerebral hemisphere in the parietal region. Parietal and the occipital region.
How do you know this is a pellet or bone?
The shape of the.
Okay.
Can be bone also, because the intensity matches with the bone. So yeah, it can be bone also. It can be the fragment of the bullet, but the shape of the hyperintensity looks more like a pellet rather than a bone.
Okay. Dr. Osman, do you have a comment on Dr. Roba's answers?
I think we can use the Houseman field to differentiate between them.
Okay, and what are the types of bullet injury to the head?
I don't have an idea.
Okay, Dr. Alpha. Remove the mute, please, before answering. Okay.
Okay. About type of injury, it is penetrating.
Okay.
Trauma,
what are other types?
injury.
What are other types than penetrating?
Could be perforating and could be tangential.
What's the difference between penetrating and perforating? Any difference between penetrating or perforating?
Yes.
What's the difference?
Penetrating, there will be inlet without outlet, and there will be the foreign body or the bullet inside the cranial cavity. And perforating, there will be inlet and outlet, and I will not see the shell within the radiology.
We call it through or in and out bullet injury. This is perforating. Yeah. Perfect. Another type of bullet injury?
Tangential. It will cause a depressed fracture with a different type of intracranial hematoma.
Tangential. Okay. Another type? Any idea about careening or ricochet type of bullet injury?
Ricochet type, yes, it will be like there will it will enter from a frontal to occipital and then go into another direction.
Okay, this is for ricochet. It's like a billiard ball, like entering the skull, hitting the contralateral wall, and again enter the brain. This is the ricochet type of bullet.
Yes.
Any idea about careening injury? Careening bullet injury, you know?
No.
Okay. Careening will enter the skull, but without entry to the brain. It runs in the subarachnoid or subdural space. It's a bullet enter in a certain obliquity. So again, the comment that about the different mechanism of injuries and about the bullet fragmentation. It's actually it's bone chips. Definitely, I will not accept that it is similar to metallic bullet, because metallic bullet will show, as you see in figure 1 and 4, the left to right
There
one,
will be
if
artifact.
it's a metallic component. Yes, there is a metallic artifact. It's not about the house field unit, Dr. Osman.
Okay.
So this is definitely a bone chips. So question for all, what's the indication of surgery in this patient? If you want to operate, what should be the indication?
Depending on the etiology and the pathology which is housing in the brain, plus the GCS of the patient.
Etiology and pathology, I couldn't understand it as indication, but
As in,
I will take the GCS as the first indication. It should be high
GCS,
or low?
low.
What do you think?
Either of it, majorly low. Any GCS less than 8 and below should be operated for removing the pathology, as in for subdural hematoma or contusion of the brain, and to decompress mainly if the GCS is low.
Okay. Dr. Osman, you have any idea about indication of operating a bullet injury?
First of all, the Glasgow Coma scale level, and then if there is obvious bleeding or the breast fracture.
Okay. So in general, it's about the Glasgow Coma scale. Low Glasgow may be an indication, but not Glasgow of 3 or 4. It's not an indication of surgery for bullet unless there is a significant extraaxial hematoma. So the indication in general is the Glasgow Coma scale, which is in the mid, not 15 nor 3. The second one is the depressive fracture, significant depressive fracture. Number 3, significant extraaxial hematoma compressing. And that's the main indication, actually. It's not about removing the metallic part. Can you tell me about the poor prognostic factor in case of bullet injury, whether clinical or radiological? And I'm searching for the...
Can you repeat the question, sir?
It's already right there. It's number 3. What are the poor prognostic factor?
Low Glasgow Coma scale.
Okay, and?
Extradural hematoma, the breast fracture, all of them
these
indication and poor prognosis.
More solid poor prognostic factor. I can accept the Glasgow. It's a solid poor prognostic factor. Any poor prognostic factor can be
associated with big
imaging.
Another associated high injury. I mean,
multisystemic or polytrauma patient also is a poor prognosis. I can accept that. Anything from imaging can indicate a poor prognosis.
Pneumokef, maybe.
No, another. Because no bullet injury without pneumocefalus in general.
Yeah.
Another point.
Injury to the major draining vessels or crossing the midline.
bullet trajectory crossing the base of a skull,
Midline.
injuring the main vessel. Yes, that's right. Crossing the midline, it's right. Another option. Crossing the midline, we call it bihemispheric. It's one of the poor prognostic factor. Also multilobar. Also trajectory crossing the ventricle. Okay.
Okay.
So that's nice in general. Some debate about the indication. It's all about discussion and the poor prognostic factor. There are many, and these are the main. And so we came here to the end of the exam. Actually, I'm so happy by the actually the interaction.
I'm also happy because still we are alive.
I will be hearing from Dr. Osman, from Dr. Ofa, from Dr. Robash about their responses now. But just to end the slide presentation, I want to thank the examiners, Dr. Mati and Dr. Zahra, about their stations, and we hope that this simulation will be fruitful for both the participant and those who follow the discussion. And after I hear your comments, the hot seat taker comments, we can answer the question from all the viewers. And yes, Dr. Osman, I want to know your feedback.
Okay, first of all, I would like to thank all of you, the examiner, specifically Dr. Samer, for this beautiful opportunity.
Thank you. Yes, we hear you, Dr. Osman.
He may have flipped off.
There is a technical problem. You can hear me now?
Yes.
Yes, we can hear you.
Okay. First of all, I would like to thank you, Dr. Samer, and Dr. John for your neurosurgical TV. I would like to thank the examiner. Thank you very much for this opportunity. I spent beautiful time. I was scared in the beginning, but in the end, I'm happy. Of course, I got a lot of information, and it was beautiful opportunity. Thank you very much.
Thank you. And Dr. Robash, are you with us?
Yes. Thanks a lot. Thank you very much to Professor Samir, and thank you, Professor John, for conducting the whole, for spending your endless time for the residents. And I know it's been difficult to spell out my name, but it's Rushab rather than Rubash.
Okay, Rushab.
Yeah, and it was a great experience for me. I know I was not very well prepared, but however, I tried my best. I was good with I hope I was good with some part of it rather than not all. And it was great being a part of the team with, I think, both the panelists, both the competitors were there other than me. Thank you.
Thank you, Dr. Roshab. And Dr. Aufa?
Thank you very much for this webinar. I need it really because I already prepared for my final exam.
Thank you. And before going to question and before going back to you, John, for the next event, it will be also the first Friday of the next month. And for those who want to participate as a hot seat taker, please register with the email found in the announcement of the event, and that would be better for us to prepare the certificates if you register all early for the exam. And back to you, John, and we are all happy till now doing this episode, and we are ready to answer any questions or suggestions.
Well, you know, it was a very interesting educational experience, SAMER. It looked enjoyable, and I thank the people for experimenting and being guinea pigs. It looked like a fun platform. I'm looking forward to the future. Thank you.
Thank you. Any question? If no question, while waiting for a question, I will ask Dr. Mati if he has any comments or advices in general, just to prepare for the
Thank you,
exam.
Dr. Samer. Thank you so much. It is a good opportunity for all of the hot seat takers to practice this virtual exam, to know their weaknesses, their strengths, and the topics of the neurosurgery. They can go and study in the weak topics for the future. Thank you so much.
Okay, thank you. And that will be a nice experience, I think, to find how you perform under stress. That's the main message of this exam. I think, Dr. The participant today have in their mind what they are good in and what the points or the weak point that they should work on it. That's the idea from this event, and for the next episode we will prepare different questions, maybe more tough questions, and it's open for all. I think it's ideal to ask 4 hot taker at a time. That will maintain the fluency of the exam. It's for the first time, even for us as examiner. So I think the next time will be better, and we will consider all the suggestions from the participant. And actually, I'm really thankful for the participant today, and we will wait for your feedback and hope that is this event you find it useful. And thank you.
Okay, very good, SAMER. I stopped recording. Very good. That looks very interesting platform. Very interesting. Has potential. The way it's used, and we'll get better with it. We'll get more comfortable. There'll be more interaction, but it shows it has potential, man, to get kids involved with their education. You know, rather than just watching something. It's great to have that.
Yes, I think I even like the interaction in the chat. It's some sort of cheating, but I like it because it's all about interaction. And I think the one who is under focus of examination cannot take comments from there and there. He will lose his focusing. But in general, it's the interaction and answering the question. It will be a nice one. And I think all of you get the idea that it's not about giving the correct diagnosis. It's about how to describe it, about the logic behind your answer. That's the main question. And if I have to give you advice, my advice is to give a flexible answers. Like while answering a specific approach, please don't say that this should be done in this approach. All other approaches are wrong. That will be mainly, that will lead you to the corner, and you will finish the exam taking a punch after the other while focusing on a specific approach and leaving others. The answer usually flexible, so the examiner cannot tell you that this is wrong or this is right. This is the flexibility that, for the pituitary, that there is 2 main approaches, something and something, but I would prefer this approach because of something and something. That's the typical, better than direct answer. Oh, I would prefer to do this one because all the other approaches are wrong. And maybe the other approaches are the one done by the examiner.
Yeah.
And
so there's a strategy for taking these tests. There's a strategy, right?
Yes. Actually, I think all the residents have a strategy in mind, but this opportunity will give them the trial to do it. Because sometimes you think, yes, I will not answer directly. I will give a general answer for each question, then step by step. But once you get in the exam and you have a false answer for question number one, maybe, so number two will be without a plan, will be just rushing into the answers. You forget your planning. So being in such situation more and more make you more confident with the answers. And actually, as I know from different exam, even in the local exam, the FRCS exam, and the Arabic board exam, it's the same. It's all the same. It's not about the case. It's not. It's how to give the principles one by one.
Is there an Arabic board for all Arab countries, or is it every country is different, has their own board?
Every country has a local board, and there is Arabic board in general. It's up to you. You want to join the Arabic board or the local board.
So that's separate. That's separate.
Yes, that's separate.
Okay.
Some country allow both. It depends.
Okay, very good. Okay, it'll be edited. It should be done in a day.
Okay, we'll wait for the video in a day to share it and get the response. For all the participants, we are really thankful for that and hope to meet you in the next episode. And we are very open for any suggestions.
Okay.
May I?
Go ahead. Anyone can give feedback now if they want, now that you're in the room.
Thank you. Thank you very much. Thank you very much. I thoroughly enjoyed. I'm a very senior neurosurgeon from UK, and I'm examiner for the FRCS and EANS. The illustrations were superb. The pace of questioning was very gentle. However, I would say, because I attend a lot of webinars, if you want to increase the educational gain for the trainees, it may be worth adding a line or two about the explanation. For example, in the beginning, there was a case, I think second case was Fromet sign and ulnar palsy. So the trainee can go away with that memory that yes, it is a Fromet sign and ulnar palsy. But more importantly, it would be to understand that it is not the opponents which is working, but it is the flexor muscle which is working. Same way, in a sun setting sign, it was fine that it was hydrocephalus, but to understand that it is a suprapineal recess which is pressing on the superior colliculi and then affecting various pathways which leads to sun setting sign. So if we can add a 1 or 2 line about explaining the importance of the sign and its relevance to the clinical or operative or any imaging finding, that's one suggestion. And second suggestion, those who are more interested in reading further, a reference to that scientific explanation from an authentic book or a paper is also worth. That will improve your performance. I mean, you have done such a fantastic job, the 3 faculty and all the people who were in hot seat. I was so impressed that illustrations were superb. The questioning style was very gentle and the courage of the trainees was exemplary. However, to add a little bit more value to the education, these 2 small suggestions, if I may make.
Okay, thank you, Dr. Bahat. As I understand that your main comment about the answers, more detail about the answer will be better, and a referenced answer for further reading will be better. That's the suggestion, and for sure, yes, we will consider that. I think with more preparation, we can make the answers more perfect. Okay.
One or two lines, doesn't have to be whole chapter, but 1 or 2 explanations that these are the fiber tracts involved in these, or these are the muscles or nerves affected, and therefore this is Fromet sign, and it is not the opponents is not working, but this muscle is working, overtaking the opponents. That's all. But excellent. I thoroughly enjoyed. In future, if I could contribute, I will be delighted. Thank you. All the three faculties and all the hot seat candidates, and John, of course. John is the grandfather of the neurosurgical education. Thank you, John.
Thank you for your comment, and you are welcomed on the hot seat. And actually, just an idea, the slides you mentioned, we put it as part of like the light type of questions, just to make the exam more neutral. The exam will be neutral if you have some simple slides. My answer is that we put these slides in a simple form, and even the question and answer for the sun-setting sign or for the forming sign, it's just to have some soft questions incomparable to other questions. That's the idea. And even in the real exam, you have some simple questions and some difficult. And for sure, we will consider your comments, and we will optimize it as possible.
No, it's all positive. I'm just suggesting to make it even better. I completely agree that we also start with what we call ice breaking. So the first exam question is always very gentle, very easy, so that the candidate feels very comfortable and has what we call icebreaker. So it's a non-threatening question, and these are very, very good questions. And I would say you have all done very hard work to get based illustrations. They were very clear. Some of the operative findings were very nice, with all the last one with the six, all the questions about opposite middle cerebral artery and infundibulum, and that was super, very nice picture. Excellent.
Thank you, Dr. Wahab.
The picture was good. The fascial colliculus and that middle cerebellar peduncle case was interesting. Somebody who spotted DVA, special congratulations for that. That was very, very exemplary. So excellent.
Okay, thank you. Really thankful for that, and I agree with your comments. And I think with the time, everything will improve, and the flow will be easier. And actually, we hide a lot of questions for the next episodes, and in each set of a question, there is 3 or 4 new different cases that take the examination to a high level to test your ability. That's the idea. And thanks.
But the well beginning is half done. So my congratulations to all. Thank you.
Thank you. Thank you. So John, we are offline now?
Yeah, we're not, actually we're on, let me get off YouTube too.